Hi, it's Stanford Erickson, Editorial Director of Chiropractic Economics. I'm here with Dr. James Gudgel, and he is the Chief Instructor with Neuromechanical Innovations. And tell us a little bit about the company and what you do, sir.
Certainly. I myself, Terry and Chris Coloco, the owner, teach a technique on the weekends to other chiropractors all around the world. And it's a technique that involves the use of an instrument to adjust the spine. Our first instrument came out about 5 years ago, electrically powered instrument that would adjust the spine, and we'd teach the doctors how to find the areas to adjust. But about a year ago, we developed a new instrument called the Impulse IQ, and we call it IQ because it's smarter. And the reason is it has an accelerometer, a device that measures motion built into the nose tip. So when I apply the instrument to a bone or to a tissue and hold it steady in that area and pull the trigger, it will measure the amount of oscillation of that bone, because when you hit the bone, it moves and rebounds back. It measures that time and says, okay, that bone has moved, it's back, it's time to hit it again or get it into motion. So this measures motion, matches the motion, speeds up to match that movement, and then when it measures 3 consecutive equal motions, it beeps and shuts off. So it tells the doctor when you've achieved maximum motion of that joint. So what we do is we start off with an analysis with the patient lying prone like this. And we begin with the SI joints because everything has to balance when the SI is up. So let's move that cord and it will start. I'm going to do this. This is called the knockless test, which is just an orthopedic test that stretches the anterior thigh muscles that makes this SI joint move into a position that is supposed to move when the hip extends. If you'll notice, on his left side, he flexes up, to let's call 140 degrees. On his right side...
Is that good?
Well, it's not how much motion. What I want to know is it symmetrical? Because I don't expect to see the same degree of motion in him as I would in a 12-year-old child, right? So I'm not looking for total motion, I'm looking for symmetry. So let's compare that to his right side. Notice on his right side, he only flexes to about, 120. So why does that knee not flex as far as this one? Because when I stretch the anterior thigh on that rectus femoris, which hooks to his ilium, this ilium does not roll forward to give him slack. So this SI joint is not moving. That's a knockless test. You can find it in any orthopedic textbook. So that shows me his right SI joint's not moving correctly. Now, there's also an association with SI joint fixations and hip muscle tightness. So let's check. On his right side, if I start at 0, this is external hip rotation. That's pretty close to normal. Look, that's good 45, 50 degrees. This is internal hip rotation. Oh, now look at that. It's hard to see for that angle, but he has maybe 15 degrees. That's not symmetrical. He should have about 45 each way. So I'm already seeing reduced flexion of that SI joint and reduced internal rotation of this hip. This SI joint causes inhibition of the maximus. So it's not working right to support the SI joint and give hip extension. So the body says, I need another muscle to help me extend my hip. So the next best muscle is the lateral hamstring. So the hamstring muscle is activated and forced to work more than it's supposed to, so it'll cause trigger points. So here's what we do. We go right down the muscle. Oh, right there. He can feel the soreness and the reaction of that muscle. So I use the IQ. I set my instrument on my high setting, which is 400 newtons. I contact that muscle, and I hold it steady and pull that trigger. And you can hear it went about 4 thrusts and shut off with no beep. That told me it did not release that muscle. I'm going to change my angle more inferior. There. I don't know if you can hear the beep on the microphone.
Heard the beep.
That beep told me it measured 3 equal releases, and that muscle's not released. Now let's go to his hip, posterior trochanter. These are the muscles that were restricting his internal rotation. So I'm going to go here behind the trochanter. Oh! Now, if you can see on the camera, see his whole leg shake? Look at that. That means this muscle is not working correctly. It's inhibited. So I'm going to go down a little bit lower. See, that's not good. A little bit higher. There. You can hear the instrument speed up and beep. That tells me I've completed that adjustment. Now the SI joint, where it's all coming from, right here. There. Now let's go back and check the motion. So remember, this had about 120. This one had about 140. Let's see if we increased it. Oh, look at that. It's even more than this side. But how about the IR? And that's more too. That's what I want. Now we have symmetrical SI movement and symmetrical hip movements. That means when he walks and his hips extend and flex, he gets proper motion on both sides. When you don't have equal motion, that extra motion is sent somewhere else, or it has to be taken from somewhere else. So when the hip won't extend properly, the low back rotates over and over and over, begins to cause stress in his back. So let's see if he's got some torque in his back. I'm going to put PDA pressure over the spinuses of 5 through 1. Here we go. 5, 4, 3, 2, 1. And I'm going to ask him, does any of those cause any pain? 5, 4, 3, 2, 1. Any of those hurt? Right there. So at about the second lumbar is where he felt pain. So I gave him 5 vertebrae to analyze in his brain which one hurt. And he told me, he said, of those 5 vertebrae that you pushed forward, the second one hurt. It did not move right. Pain over bone is an accurate measurement. So now I'm going to switch my attachments. I'm going to take the single stylus out, take my large dual stylus. It's large so it can fit on each side of the spinous process, lumbar spine. Go to the second lumbar, contact it, hold it down, and thrust. There. It went about 8 times and it beeped. Let's go back and see if it changed the sensitivity. Here we go. 5, 4, 3, 2, 1. How'd that feel? Much less pain. Now, we go up here. We do the same thing. Let's check extension of his neck. Does this cause you any pain? Now, he said no pain, plus I also felt his neck go into nice, good lordosis. It moved nicely. So let's check lateral bending. I'm going to go lateral bending to the, nope, you go limp. So now this is all passive tests. I want them to stay released and relax. I don't want his muscles to contract to force that joint to move around a fixation. I want him to stay passive so I can feel it. So here we go. Lateral bending left, he goes about 25 degrees. Lateral bending right, oh, he goes 40 degrees. He doesn't go to the left. Something between 3 through 7, which is where lateral bending comes from, is not moving. So let's go back up here, take the instrument, switch back to the single stylus. So I'm going to go on one side. I'm going to start with the 3rd cervical on my medium setting, which is 200 newtons, right there. Right here. C3 left side, right there. There. You hear it speed up, it beeps, shuts off. Now let's see if it increased his motion. Oh, look at that. Any pain with that? We got equal motion both ways. Next is the top 2 vertebrae. Rotation to the right and rotation to the left. Nope, he doesn't go to his left. So in addition to lateral bending being restricted, the left, rotation to the left is restricted. C2 on the left, right here. Wow, now see that took about twice as long as the other one did. Now rotation is much better. Any pain with that? So now I've got good motion with no pain. That's what I want. I want functional improvement. But I still have the thoracics, right? Let's go from 1 down to 12 and 1 down to 12. Okay, there's an area of soreness, an area of tension, an area of spasm right here. And the rib right next to it. That's about his 5th thoracic. Let's try it again. Here we go. Any pain through here now? Or here? Nope, good. See, now I've thoroughly scanned from his pelvic muscles, hip muscles, to his SIs, to his spine, all the way to his neck. I can now put motion in the areas without pain. I can put range of motion there. I can do Noctis tests. Everything is functionally improved, and that's what I want. So let's stand him up, make sure he feels better.
Now, can we do anything with his head?
Well,
we can't improve.
I don't know.
Oh, no.
We'll send him back to school. Maybe that. Anyway, he was a good patient.
No, Manny Leary was not only good patient, good employment.
That's good.
The head we'd like to adjust.
So, does that feel a little easier up to your upper back where you had that? Yeah.
Yeah, very much.
Because see, your neck was stiff on that one side. And it was causing referral pain down that shoulder blade. But that's how we do it. And the thing about this, it's a very patient-intensive treatment. You can feel me. I'm into you. I'm touching you. I'm moving you. People get off the table and they say, I've never felt so thoroughly examined before because I didn't leave anything uncovered. Now we do extremities as well. I didn't do extremity work on you because you had no complaints. But that's our typical spinal from the pelvis all the way up. So it's a full body area. We find the areas that are restricted. We fix them. The instrument tells me when the bone is released, and then I reconfirm it with my orthopedic tests.
Dr. Jim, thank you very much.
I enjoyed it.
Manny Leary, how do you
Thank
feel,
you.
Manny?
I started out with pain. I feel no pain right now. Thank you, Dr. Jim.
I'll pay you later. All right, thank you.
Bye-bye. Okay.